for this excellent introduction to the topic. I now invite all the other panel members and introduce them shortly to you. Jess Dyson from Newcastle, Kumari Efe from Diyarbakir, and Michael Manns, whom you all know from Hanover Medical School. And the first question actually goes to you, and you asked it yourself on the last slide. So before thinking about second and third line treatment, I think we should optimize first line treatment. And can you tell us what you do in your clinical practice to do that? Also regarding levels of metabolites and acceptable leukocyte counts, for example. That was one question from the Q&A under AZA treatment.
Thank you, Professor Schramm. I appreciate it. Certainly, from the standpoint of maximizing first-line therapy, I think that is something that I have grown in my own practice in recent years. I had not traditionally been tapering or adjusting medications based on metabolites, but I do believe increasingly that does have a role. In terms of looking for side effects or toxicity from azathioprine, I do routinely now send to PMT to identify poor metabolizers, and overall, I have not had significant problems in patients who have leukopenia from azathioprine. I think that, to be frank, I have pushed myself in recent years to attempt a greater degree of steroid withdrawal by maximizing azathioprine, although I think that is still a work in progress.
I think that is a very important topic in order to reduce steroids, and you nicely showed that in the UK, and the same is true for Germany. More than half of patients still are on steroids. And Jess, I think you published these data. What can we do in order to minimize steroid exposure in our patients?
Thank you, Christoph. I think part of the problem is maybe people not being very aware of what we should be aiming for. I think a lot of people do aim for a low dose of steroids running alongside azathioprine, in contrast to the guidelines, which would suggest azathioprine monotherapy being our goal. So I think a better education of our kind of clinical community about what we should be aiming for, and very proactive. Certainly, I think the same as David, I very proactively give really almost everybody a chance at trying to get off corticosteroids. The only caveat to that would be potentially advanced cirrhotics or people who are decompensated at the time of presentation. But I think part of our treatment algorithm should probably be an attempt at withdrawal of steroids. And once we've achieved biochemical remission, we've maintained that for, I mean, there's a discussion in itself, but whether that be a year or more, and then give people a trial of steroid withdrawal.
Thank you. And I think budesonide is an alternative, and Professor Manns has published this beautiful trial more than 10 years ago now. Professor Manns, do you want to comment on the use of budesonide in first line and even second line treatment?
Yeah, I think there are two. Can you understand me?
Yes.
Yeah, I mean, there are two issues. The one is response, and the other is tolerability. I think prospectively you can use budesonide in first-line treatment, although we have to acknowledge that the trial was in combination with azathioprine, not as monotherapy. And the other thing is, in second line, I mean, this study was first line, and the question is second line, this is for intolerance. There's interesting study also coming out of Hamburg, whether in intolerant patient it can be used instead of prednisolone. I think this is an alternative. But if patients do not respond, I think budesonide is not the right choice. What is very interesting is, I think, the studies on the treatment response. I mean, this is not only on budesonide. I think Dr. Assis has clearly shown that normalization of ALT or AST is very, very crucial. And I think this we have to choose independent which drug we should use. And budesonide should not be used, as mentioned before, in cirrhotic patients. Otherwise, in mild disease, non-cirrhotic, I think it can be used as an alternative, in particular in patients with the danger of steroid-specific side effects like bone disease, diabetes, and so on.
I completely agree. Thank you. There was another question from the audience whether we can use mercaptopurine instead of azathioprine, and maybe it's even associated with less side effects. Richard, do you want to comment on that? Do you have experience with that?
To be honest, no. I myself never used 6-mercaptopurine, so
Okay.
I'm not aware of data directly comparing ASA and 6-MP in AIH. So are you aware, Christoph?
Yeah, Professor Manz, I think, wanted to comment on that.
I think that there are not enough data available. There are very limited retrospective data, and I really want to refer to the last AASLD guidelines, and maybe David Assis can comment. There has been a huge effort, and AASLD has taken a lot of money into their hands to finance the analysis of the trials. And I think at the end of the day, they analyzed 1,732 trials or something like that, and they came out with 2 trials that met the criteria eligible for analysis. Maybe, David, you can comment on this. And I think this analysis has not been done before. So I think 6-mercaptopurine is only retrospective data as far as I know.
Yeah, thank you, Professor Mons. I think we were both in the effort at updating the AASLD guidelines, and surprisingly or not, perhaps the net outcome from searching through thousands of articles from a high-quality meta-analysis standpoint was quite sad, I would say, in that the number of articles were so minimal to be able to have meaningful comparisons were very, very small. And I think it really points to the need for randomized studies in the next 10 years so that future guidelines can have better evidence behind them. But I think it was an eye-opening experience to go through that and realize how much of the literature that we base our recommendations on are case series and retrospective studies.
So I agree to that. I may be able to add that we in Hamburg use quite a lot mercaptopurine, especially in those patients with GI side effects, and it works quite well, but that's anecdotal. So before thinking of second-line treatment, we have to define what is a treatment failure, right? When to introduce second or third-line treatment. What is your thought about that, Kumali? What is the treatment goal, and when do we have to think about second-line treatment in our patients?
Yes, I was just considering about this question just 5 minutes before. Yes, this is really important question because we don't know exact timeline for the definition of treatment response from the initiation of the first-line therapy. For example, some patients respond in a few months, but the other group show complete response after 2 or 3 years. Because recently I have a patient. She entered complete response after 3 years of therapy. So this behavior of disease may lead overuse second line or may lead delay in use of second line therapy. Actually, we all aim to reach normalization of aminotransferase plus IgG levels, but for me one of the best AIH study from the UK by the German Dermot Giliasson and et al. Showed histological activity may persist despite complete normalization of aminotransferase, and this activity is associated with poor outcome. So I think we should aim lower, maybe lower than half time upper normal limit aminotransferase levels.
So I think as low as possible, and I think we should be especially careful in the cirrhotic patient with AIH because we miss histological activity if we only focus on biochemistry.
Yes.
Kumali, before thinking about more intense immunosuppression, our patients are worried about COVID. And you just recently published a nice study in hepatology. Can you, from a practical point of view, comment on the specifics of treatment of AIH during the pandemic?
During the pandemic, you know, all our study as published by your group, both showed immunosuppression therapy maintains or withdrawn does not affect outcome. But we still don't know baseline therapy affect outcome of this patient because we know immunosuppression effect of azathioprine or MMF or steroid may persist several weeks despite their withdrawal. So we now evaluate outcome of baseline therapies. We now have over than 255 patients. We indeed unexpectedly or maybe expectedly we showed azathioprine and steroid baseline therapy are associated with worse outcome. So it is not surprisingly to show withdrawal or maintenance therapy does not affect outcome. As I told you, their immunosuppressive effect may persist several weeks despite their withdrawal.
Yes, thank you. And coming to second and third line treatment, what is the best choice for those intolerant to standard first line treatment? David, what do you think?
It's a good question. In my personal practice, I tend to evaluate several factors such as the degree of aggressive autoimmune hepatitis, pros and cons, especially in relationship to chronic kidney disease. And my personal approach is if a patient is really failing optimized azathioprine therapy, and I have not found that substitution with MMF or CellCept has been very successful, and so I've increasingly relied on low dosing of calcineurin inhibitors such as tacrolimus. I think for patients who aren't tolerating azathioprine, I expect MMF or CellCept to work much better, but I have increasingly relied on tacro for these patients.
Thank you. Any comments from the pediatric side? Rodrigo, do you want to comment on that?
I'm not a pediatrician, but I learned from pediatricians. Well, on the pediatric side, there's the data that is out there points for equal or efficacy of both MMF and tacrolimus in non-responsive patients, which is slightly different from what we found in adult patients, where MMF is mostly effective in patients who are intolerant to azathioprine and not non-responders. In patients intolerant to prednisolone, there is less data regarding budesonide, again, in pediatric patients, although there is the trial published there. It was not for intolerant patients, but for first-line therapy compared to adult patients. On the other hand, there is a lot of data, even as first-line therapy, some data in what regards calcineurin inhibitors and also cyclosporine, both as first-line therapy and as second-line therapy in pediatric patients.
Thank you, Rodrigo. I think what we clearly need is clinical trials and prospective registries, and there's no other person with more experience in clinical trials in AIH than Professor Manz. We have ongoing but poorly recruiting clinical trials. Professor Manz, what can we do in the design of these trials to improve recruitment and to in the end get meaningful results?
Christoph, thank you very, very much. I think this experience with the trials is very, very painful. Let me give very few comments. Number one is none of second and third line therapies is approved, none. So I think we need prospective trials, and we need to encourage industry to invest. And you know, autoimmune hepatitis is a rare disease, and non-responders to standard of care. We learned from David that standard of care today is standard of care of 1980. So we have to convince them to invest. And then the problem is when the study protocol is designed, then the industry, after discussing with us, they go to the regulatory authorities and they add to the inclusion-exclusion criteria. So that at the end of the day, the definition of a non-respond is only aiming at a very small proportion of patients. For example, these patients, if you say they have to have been treated with standard of care for 6 months, and not responding and not achieving normal ALT. The problem is that very few, even of our centers, can document that the patients have received the therapy for 6 months. And therefore, we fail to recruit the number of patients. I think we all have to work together. And the other issue is there should not be too many competing trials around at the same time, because then we will not recruit. And the other issue is the people at industry that design the trials, they are like us, have a passion and they want to get this going. But the upper management at the end is deciding whether the program is further financed. And they say, if you don't recruit for the trial, how should there be a market afterwards? So in summary, we have to work that the inclusion and exclusion criteria are not too strict. We should not have too many competing trials at the same time and should collaborate to recruit timely.
Thank you very much. I think that was an excellent concluding statement. Our time is up. I would like to thank all the panel members, all the speakers for their excellent presentations, the audience, over 300 participants for asking questions and for being with us. And I wish you all an interesting and exciting ILC 2021. Bye-bye.
Thank you very much for sharing. Thank you very, very
much.
Thank you.
Thank you.
Bye-bye.
Bye-bye.